Morning, Breaking Barriers 2020. I'm Dr. Jim Kooler with the Department of Healthcare Services, and
hi, I'm Greg Rose, Deputy Director for Children and Family Services at the Department of Social Services.
And we're here this morning. Following Toby Ewing is never an easy task, but we have the opportunity to talk to you a little bit about the Foster Care Model of Care Work Group, which is part of the overall effort at the Department of Healthcare Services and at the Department of Social Services, taking a look at how we do better in serving young people in the foster care system. The Foster Care Model of Care Work Group is part of the overall CAL-AIM, the Advancing Innovations in Medi-Cal effort, which started several years ago with a listening tour of our leadership going around the state and finding out what were the real challenges in Medi-Cal and what could we do to make it better. So we will be able to do some of those changes through a work group process that's been going on for over a year. And the Foster Care Model of Care is one of those work groups. So there will be a waiver process starting in the spring of 2021 with implementation in 2022. So our Foster Care Model of Care Work Group has been working since the middle of last year. Hopefully we had planned to start in April, but a little virus thing came up and kind of delayed our launch, as most of the world was delayed. So let us tell you a little bit more about the work group.
Great. So I'd like to just kind of do a little bit of level setting and talk with you about the Model of Care Work Group. And so really one of the things that we're looking at for for the population of children in foster care and known to the child welfare system, given what was heard at the listening session, given the listening sessions, and given the information that many of you are aware of, given with respect to outcomes for kids in foster care, the administration really felt it was important to take a deeper dive and look at this subpopulation, its particular needs as related to trauma and other adversities. And so we're really looking at a way to provide physical, dental, behavioral health, and social services in as integrated as a fashion as possible, in a holistic kind of whole person approach to the work. And so this particular group of young people, there have a set of circumstances and experiences with respect to a number of the systems that are represented often in the Breaking Barriers audience that really requires a kind of deeper, more specific dive into the work. And so a little bit more about just who we are and kind of where we're headed. Is that the work group membership is about 30 some odd people strong, and as you can imagine, there was quite a bit of interest in young people in foster care, their caregivers and their parents, and so selecting this work group was no small task. But it's made up of both folks that are subject matter experts in delivering healthcare, dental care, behavioral health experts, clinicians, people that are connected to the social services world and foster care case management, child welfare, et cetera, and the Judicial Council, given so much work with this group of young people involves courts. So the membership is very much very subject matter specific and very has a great deal of expertise. That said, there are of course some spaces at the table for tribal partners and people with lived experience, whether they're caregivers or young people in care themselves. And should just note that probably sometime before we end, Jim and I will talk with you about our intent and our process to get additional information from people with lived experience into the work group beyond the membership, et cetera. As you can see, we've met a few times so far, July, August, and July, August, October, and then a meeting coming up on December 17th. Largely at that point, there's been I would say, kind of formative kinds of processes going on. The group kind of coming together and coalescing around a specific kind of set of goals, and at the same time, we've been we've provided some space for people to understand what's happening in other jurisdictions around the country. And we've spent some time having some conversations with folks from associations and other formal bodies, all of whom have spent some time thinking about these issues and have provided some formal proposals to the group. So there's a proposal to the group from the CBHDA and CWDA, that's the county welfare directors and the county mental health directors. There's been a group, a subset or a subgroup from the Child Welfare Council that's been doing some deep thinking on this issue and has provided some feedback as well. So what we're really trying to do is take all of the information that's currently available, expertise from the field and from people with lived experience, put them together in a coherent kind of package that could be presented to our federal partners and others within the state to think about how we, not to think about, but to actually deliver high quality health, behavioral health, dental care to kids in the child welfare system. Jim?
And Greg, I'm guessing that maybe some of the folks who are with us today have either attended one of the meetings, or we might even have some of the council members on here. So if you want to go into the chat, if you've had a chance to attend, and just give us a yes, you've attended, or if you're one of our work group members, please say hi. We would love your input as well as we go through this morning's presentation and this conversation. So when we think about some of the things that we may have accomplished or things that we want to do, I think in just the short time we have been together, one of the issues that has come up that I think we've actually been able to make progress on is medical necessity. And the idea that when a young person is in the foster care system, that we may not really need to go through some of the steps that we used to prove medical necessity. I think we've come to the agreement that the amount of trauma that they have experienced automatically would make them eligible for services, though still needing to show that they need those services, but eliminating at least that first step in the barrier to receiving services. So medical necessity will be one of the things that will be moved forward into the first round of the CalAIM waiver process. And as a reminder, that CalAIM evolution of our Medi-Cal services is a multi-year effort. So though not everything will happen in the first year, the work group will be coming up with innovations for this population that continue to be able to be advanced as we go forward. Some of the other things we've heard about are the personal electronic health records, how challenging it can be at times to have young people have to present and re-present their background. Trying to find a way to make that easier through electronic health records. And in some of the research we've seen this been tried many times before and not been successful. So trying to figure out what are the innovations, what is the technology available today that we might be more successful. So the website for the work group is listed there. And if you have email questions, you can send it to the CalAIM foster@dhcs.ca.gov, and we can take questions from you directly there. So I think, Greg, that gives a quick overview of the work group process. And I think our hope now is to really spend some time taking questions out of the Q&A and finding out what are you all from the Breaking Barriers world want to know, or how can we give you some insights as to what the work group is doing?
Right, and Jim, as people are thinking about their questions and potentially typing them into the Q&A or into the chat, I just did one. I kind of did a teaser that we were trying to get information from people with lived experience into the session as well, and so just wanted to describe that a little bit for folks so that they have a sense of how that's going about. One of the things that where Jim and I have seen eye to eye in this process is to make sure that we really pay attention to, in essence, consumer voice and choice around their identifying their needs and how services can be delivered. And we didn't have a big enough table on an ongoing basis to have as many people with lived experiences as we had, as we know we needed. And so Jim had an idea some time ago that I've piggybacked on, and that Jim through the Department of Healthcare Services and one of their contractors set up a handful of focus groups, listening sessions with current and former foster youth to understand their experiences of getting healthcare, dental care, and the all-important for this population behavioral health care that includes substance use and other therapies. I, through my department and some of my colleagues, are in the process now between the two holidays, if you will, to also to have conversations with parents who've had their experience with both the child welfare system and accessing services through Medi-Cal, with caregivers who are relative caregivers who are taking care of young people who are in foster care but are their relatives, and also with what we've also sometimes now called community families. So those unrelated foster parents that are providing care, nurturing, and love to our kids while they're working through reunification or other issues. And so we will be taking the insights from those listening sessions back to the work group on in December, on December 17th, so that we can infuse not only the kind of formal association thinking and what other states have done, but also do our best to provide these insights to the group as well. One last thing I'd say, Jim, I'm making a pitch. I'm not seeing a whole bunch of stuff in the Q&A at the moment. So one other thing I would say is these are in fact open public meetings, and even though and they're held over Zoom, no doubt, like everything else these days. And one of the things that that's important to note is that there is public comment at the end of the meeting. So for folks who feel like they have some additional insights, they want to observe the proceedings and then provide a couple of minutes of their expertise or their observations, we're certainly open to that.
Looks like I'm getting a sense that there are some thoughts and questions out there, and one of those is, what are we hearing from young people? And your pitch is exactly right, because this is the teaser. If you want to see the report out on what we're hearing from young people, join us at our next foster care model care work group, December 17th. No charge, just sign on and join us. So you'll get to see the report out from that. We also, go ahead.
No, I was just going to say there's a couple of questions. I noticed one, there's an interest in maybe talking a little bit more about medical necessity. I think that's potentially in your bailiwick. And then as we're thinking about it, there's also some questions that are coming in related to us collaborating with schools, and what are the primary themes you're getting from young people. And then there's also a question about the 0 to 5 population may not be participating in our focus groups, and how are we thinking about them in some ways.
So one of the things that we knew early on is that there are many efforts focused on supporting young people in the foster care system. And this work group is specifically focused on those medical, dental, behavioral, and social services and how they link together. and not intended to address and fix all the elements that might not be going as well as they could be. So when you think of the system of care, or you think about some of the other work groups going on, we are working in parallel with that to try and address specifically the healthcare needs for these young people. So the interface with the system of care, the AB 2083, SB 75, I apologize, way too many numbers, but those work groups are all addressing their needs, and the work of this group, I believe, feeds into that to address the questions that come up in those work groups relative to the healthcare, dental services, and taking a look at outcomes that might really speak to the quality of the young person's life, not just the delivery of the services. So really, our work group is trying to move beyond the standard measures that we might use in healthcare services that would show success, and think about how that impacts the social services results for young people as well. So that might address a few of those questions. The children 0 to 5, I think that may get picked up more in some of the focus groups, Greg, you're working with some of the caregivers. They'll have insights more than anything than the groups that we will be working with.
That's right. And we do have pediatricians and other clinical expertise on the work group. We've been hearing, we have a constant, one of our favorite public commenters is a pediatrician from Contra Costa. So each session we hear a bit from his perspective, which I think is valuable. With respect to schools, I would say this. Two things. Some of the folks on the work group have expertise because they're providing services currently as a contractor on schools. Some are school board members. To the degree possible, we actually tried to grab twofers when we could get people with multiple kinds of had multiple experiences on the role. The main work that we're doing, though, with crossing over with special ed and with behavioral health and social services is really in our AB 2083 work group. There's a very deep and robust discussion about how to best serve those young people with those particular needs. That work also gets infused into into these conversations through overlapping membership and through the diligence of our kind of coordinating body to make sure that we're able to try to funnel in the appropriate information. There's a question also about ACEs and FFPSA, so the Family First Prevention Services Act. And certainly I'll say this, David, with respect to ACEs, we have been focusing a fair amount within the administration, as you know, since the Surgeon General came on board around ACEs. Prior to that, we'd been really thinking about trauma, and trauma and ACEs obviously go hand in hand. So there is and we are looking at, especially because of the healthcare delivery service process, there's requirements for assessment around ACEs as part of primary care these days. And so that will be, those thoughts will be integrated into, or can be integrated into the ultimate recommendations. With respect to Family First Prevention and Services Act, this work group probably is kind of working around the edges, if you will, on that. There are deliberate efforts between the Department of Social Services, the Department of Developmental Services, the Department of Social Services, and what will largely be a stakeholder informing process as well, starting the end of the year, or the beginning of next year, I should say, to think through how best to implement the new federal law. That said, we should be aware that if we're thinking about delivering services through Medi-Cal, and that there's an opportunity to serve kids and families more upstream with through FFPSA, we have to be thoughtful about that. For example, FFPSA requires social services to be the payer of last resort. So we'll have to coordinate to make sure parents who are eligible for Medi-Cal can get services through that way. And if not, then we can kick in, we can think through the social service side. So a lot of things happening, as you can imagine, and rather than having this work group try to tackle it all, as Jim has described, and as Jim helps us stay focused, is there's a particular niche right here that we're trying to address and yet be informed by all those other moving parts.
And that is the art of this work group, of trying to solve some of these problems while doing it in a interactive and interfacing way with the much larger efforts that have been underway for a longer time. So the question about data has come up, and I believe that the recommendation of our work group will be that we have a specific effort to really identify what is the best data and how can we capture it in a more effective way to show how our work is making a difference. So I don't believe that there will be specific data elements identified by this group, but a process to gather people to identify what is the right data so that we can do this correctly with the people who work most closely with the data and with our systems. So data has definitely been an issue. The challenge of trying to identify what is the right database, what's the right match data, we spent a fair amount of time trying to figure that out. And I believe the work group will most likely recommend that we continue down that area and not have specific data recommendations coming
Right, I think I would just like to expand. There's a couple more questions coming in from data, and then there's another question from Marty, Jim, that we might want to talk about kids who aren't in foster care. But with respect to the data, we're taking a staged approach. Once we understand the recommendations and the recommendations get adopted, those will be in essence kind of markers for, that will be the goal for success. Once we understand that, then we will, as Jim notes, we'll grab a group of people who have specific expertise to think about how do we measure those things. So we obviously will have process measures and we'll count units of service and things, but we are also more interested in trying to answer what I often call the so what question, or the impact question, is did young people, get better? Did they, if they have a condition that can get better, how do we know that the treatment that they got made a difference in their lives, either by maintaining a level of functioning that or by improving it? So we'll be convening a separate group, as Jim notes, for that. And I think the exciting part for me is, it will obviously be looking at health outcomes and behavioral health outcomes, but we're also given that success for this group of kids also is success around schools, success in relationships, and given the interaction with the social determinants of health, et cetera, it gives us a chance with fresh eyes to think about how are we going to take advantage of some of the shared administrative data that we now have available to us, and really do a much deeper dive than we have historically done by kind of counting widgets. Jim, I don't know if you want to speak to Marty's question around, I think the larger CalAIM process speaks to some children's issues, but.
Right, so Marty's question is about youth who are not in the foster care system but would be medically eligible. Their needs are not being discussed specifically within this work group. This work group is really staying focused on those who are in the foster care system or eminently eligible to be involved using the FFPSA definitions. So those other young people and their supports are being addressed in the larger CalAIM work groups.
Thanks.
Well, there have been more questions coming in than I expected. This is great. So other questions that we might have missed here as we scroll through it.
There is a question as have performance goals for achieving, has there been agreement? And I would say the agreement is that there needs to be some, and that there needs to be agreements about them. But as I said earlier, I don't think that this work group is in the position to define all that. I know that there is, given the preliminary conversations, and not to be overly redundant, as Jim noted, there have been discussions thus far and will likely end up with other recommendations to be thoughtful about that, probably building on the kinds of things that some of you may have seen through the DHCS's performance outcome system, or our California Child and Family Services Review, that kind of stuff. And we also have case-specific data we can look at. So I think we're going to want to look at it with fresh eyes, with people who have a stake in it, and people who understand how best to measure things.
And I think one of the strengths of this work group has been that it's been a joint effort between social services and healthcare services, that Greg and his team have very gently adjusted my way of thinking on broader outcomes than the ones that we may have traditionally looked at and measured within our own system. So I think together we're looking at the world with new eyes, and really keeping young people and their families at the center of what this work will do to improve the quality of care for them as we go forward. So I think, go ahead, Greg.
I was just saying, Jim, as I was thinking, one of the questions earlier on was, about schools and coordinating with schools. And I would venture to say that there are plenty of models of service and areas in which young people are getting their health and behavioral health and some of their social services needs on the campus that they attend. And I would imagine, but I won't, predict specifically, that some of the recommendations that come out of the work group will obviously be building on kind of the existing service system that is in play, and building on successes. And given that the approach from the administration, especially these two departments, around meeting the needs of kids and families, is really trying to focus on the family, the child within a family unit, the family unit within the context of community, which includes school and other natural supports and places where people go for services and supports and social connections. And so while we haven't had an exclusive section or segment on schools, I would expect that many of the recommendations would play out in a way that would likely need to partner with our school partners.
I would agree. And as we come to close, just thinking about the Thanksgiving holiday coming up, just thanks to all of you for your commitment to young people and making our communities better, and all of us doing what needs to be done to wear a mask, wash our hands, stay physically separated but socially connected. So Greg, good job. A high five. There you go. Quick high five to the camera. There you go. Now please sanitize. Very nicely done. And Richard, I think you take us out. So thank you all so much for the opportunity.
Thank you.
Thank you so much for bringing voice to the really thoughtful work of the State Foster Care Mental Health Work Group, and how it's so critically connected to other Medi-Cal reforms that are in process and conversation, and how it supports the system of care work going forward. Really appreciate your time and wisdom this morning.